Hi, and welcome to another Facebook Live. My name's Jo Gibson. I'm a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit and also a consultant in private practice. Now, for various reasons, I've managed to get on here at the normal time this evening. As I said last week, I didn't think I'd be able to, but for circumstances beyond my control, other plans went awry. So I've been able to pop on here for a quick 15 minutes to continue talking about all things shoulders. Now, I'm really excited to announce that today we've released the first of our 3 webinar series looking at all things frozen shoulder. Hello to everybody who's joining us. And there are 3 webinars really looking specifically at frozen shoulder, both in terms of where we're at in terms of our understanding of the pathophysiology, how that links to some of the common risk factors, and really shining a light perhaps on some modifiable features that we can think about reflecting in our treatment. As I say, part one's out today. If you want to have a look at that, then go along to clinicaledge.co/frozen shoulder, and you can access all that information there. Now, this week, I'm going to pop on every evening, actually, to talk about things all stiff shoulder to complement that webinar series. I won't be talking about frozen shoulder because that's covered pretty expansively within that webinar series, but I am going to talk about some other causes of stiffness and what that might mean to our treatment, just to kind of have a bit of a stiffness fest this week. So great to see so many of you joining us. So I guess let's take a patient. A patient comes to us. He's fallen over, let's say 8 weeks ago. He had immediate onset of pain, loss of function. He's 52. He has private healthcare, so he's been to see a surgeon, and the surgeon said, "I'm going to operate." He's got a traumatic tear. And remember, if we've got somebody who has a history of trauma, the things that make us kind of more suspicious that surgery may be an option in that situation is a group that have immediate onset of pain and loss of function, and particularly if that's not improving significantly over 2 and 6 weeks after the original injury. So this guy ticks a lot of those boxes. He likes going to the gym, he likes skiing, he's pretty active, and he's very keen to get back to that. Now, he's going to have his surgery. So in terms of my planning, if you like, of his post-op rehab, what are the things that are going to dictate whether I get him moving early or not? Well, the first thing is the surgeon, because if the surgeon is very conservative and wants to have a period of immobilisation, then that's clearly something that I've got to consider. But I guess the first thing is we generally want to mobilise people earlier because we want to stop them getting stiff. So in lieu of what we're talking about this week, how can we predict people that are likely to get stiff, and particularly around rotator cuff repair? Well, if we look at the kind of common factors, and some of these will be very familiar to you because they're aligned with our frozen shoulder groups, there's no doubt if he had diabetes, if he had thyroid dysfunction, if he had cardiovascular disease, none of which he has, those would all be risk factors. If he had Dupuytren's, again, that would be a risk factor. But interestingly, there's been a couple of studies recently suggesting that gastroesophageal reflux disease is a risk factor for developing post-op stiffness. So that's a new one from Cucci et al. Obesity, again, because of the impact on metabolic inflammation at a cellular level. So obesity, he's not obese, so I'm doing all right so far. There's not many factors that I've got to worry about at the moment. Hypercholesterolemia, again, that lipid concentration in the blood seems to predispose to developing stiffness. Cervical spine involvement, interestingly. Now, we don't have masses of evidence to support this. We do have evidence that concomitant cervical spine involvement in somebody who goes for shoulder surgery will mean they'll probably have more post-op pain, and they'll have a more protracted recovery. He's not a female, which is from his perspective good, because unfortunately women do seem to have more pain in the first 3 months post-operatively. So again, just in terms of setting in expectations, if it was a female having rotator cuff, I'd expect those pain levels to be a little bit higher, and that may contribute to a slightly increased risk of developing stiffness, even more so if she's perimenopausal. Now, stress and psychosocial factors are getting increasing interest in their potential role in driving stiffness. And again, they have a cellular level effect at the extracellular matrix, which again seems to predispose people to get stiff. So as ever with this gentleman, I've got to explore his expectations, any fear about the surgery, and make sure he's got a clear understanding of what's going to happen. Now, those are like those kind of patient factors. But what about surgical factors? Is there anything that I need to know from the surgeon, or anything about his age or anything else that might be relevant. Well, interestingly, it's the younger patients with traumatic tears that have a bigger risk of getting stiffness than some of our older degenerative populations. Certainly, that under 50 post-trauma group are very likely to get stiff. Let's say he'd done something as well as his cuff, that maybe he's injured his biceps or he's injured his labrum as well. Equally, having more than one procedure at the same time increases the risk of surgery. If there's a current calcific deposit, even if it's something that's been there for a long time, again, that seems to relatively increase the risk of developing stiffness. So there's some things we need to know from imaging and from our surgeon so that we're not kind of planning our rehab in the dark. We've kind of got all the information that we need. Now, immobilisation in itself is a risk factor for getting stiffness, and obviously we'll come back to that. But the other interesting thing is, you in your post-op notes, you always want to take a note at what they found about biceps, because again, long-headed biceps pathology, if there's any significant synovitis, again, that seems to be a predictive factor for developing stiffness. Now, with this guy, he's had trauma, he's 50. If he had pre-op stiffness, then again, he would be more likely to develop post-op stiffness too. So some key things that we need to consider. Now, the really interesting thing, if I have got a surgeon that's conservative, then I'm going to try and educate him. But equally, I need to be respectful of what he thinks, because a very important message when we talk about stiffness in the post-op shoulder, we get really excited about wanting to mobilize everybody. And there's no doubt, and I'm guilty of that, because there is clear evidence that if we do early mobilization interventions, people get back to function quicker. And for a guy like this who wants to get back in the gym and do those sorts of things, then clearly that's important. And increasingly, there is evidence to support that if you look at patients with small to medium tears, so under 3 centimeters, the bottom line is, with good tissue quality, which you would hope somebody who's fit and healthy and 50 or 52 will have, that actually early mobilization, or just giving patient guidance, if you like, about safety cues, so a safe zone that they can mobilize in, not lifting anything too heavy early doors, keeping their symptoms at an acceptable level, actually increasingly that's being shown to be as effective. No more risky, if you like, in terms of re-tear rate than sticking somebody in a sling for 6 weeks and then getting them out and knowing that it's going to take them longer to get back to where they are. So this early mobilization is increasingly supported. And if you look at the pull-out strength of some of the suture anchors and things that they use to do the rotator cuff repair, it's really advanced. And yet, interestingly, when you look at surveys of practice, maybe post-op rehab hasn't moved at quite a pace, but I do think there's a real shift and we're getting increasing evidence to support it. Now, having said that, there are some groups that are more likely to fail, so are more likely to get a re-tear. So if we know those things, if we know who's likely to get stiff, but we also know the potential risk factors for somebody failing a rotator cuff repair, then we can decide whether it's reasonable to do early mobilization or be a bit more conservative. So if we look at the factors around why people tend to fail or don't even heal in the first place, there's some common themes. About the tear itself, so no great surprise, big degenerative tears, so 5 centimeters or bigger, more than one tendon, have a far higher a far higher rate of failure. Similarly, if there is fatty infiltration, so again, you see that theme that degenerative tears, where you've got replacement of the tissue with fatty tissue, is not a great indication for integrity long term. And if you look at follow-up studies, particularly in the over 60 and even more so the over 65 group, then anywhere between 30 and 90% of patients, when you re-image them at 6 and 12 months, have either not healed or got a re-tear. And a large proportion of failure is in the first 3 to 6 months. So just something to be aware of. Now, in terms of risk factors, looking at patient factors again, increasing age. So the more over 60 you are, the more likely you are to fail. Obesity is a big risk factor, again, probably because of lipid content and some of those cellular level responses. Diabetes. Interestingly, osteoporosis or reduced bone mineral density, there seems to be a reduced pull-out strength of some of the suture anchors, so that can predispose to failure. Smoking, well reported. Jury's a little bit out about how many injections somebody's had before their surgery, but again, if somebody's had a lot in a relatively short period of time, might be something to be aware of. And interestingly, vitamin D deficiency. So the key thing is, when you think about the patient I've shared with you, he's 52, he's got a 2 centimeter tear, it was traumatic, he's quite a high chance of getting stiff. He wants to get back to the gym. He's got pretty high functional demands in terms of what he does with his job and all the things that are his valued activities. So he is somebody that I want to get mobilizing early. Now, of course, I want to keep that safe, and we'll talk later in the week about what I can do. We've talked about cross education in a previous Facebook Live, but there's lots of other strategies we can do to keep it safe, keep our surgeon happy, but importantly, minimize the risk of this gentleman developing a significant stiffness. Now, having said that, the one thing I would say is that if somebody gets stiffness, don't panic. If you look at long-term follow-up of patients with rotator cuff repairs who do get a stiff shoulder, the bottom line is if you look at them at 12 months and actually earlier in some studies, it evens out over time. There's no doubt early mobilization gets patients back to what they want to do quicker and with less pain in those small and medium tears, less convincing in the larger tears. But importantly, those patients who do get stiff, if we look at them at 12 months down the line, the bottom line is it evens out. And we have to respect our surgical colleagues. They don't keep people immobilized just because they fancy it. It's because their belief is that's the best thing for that patient. And there's certainly some surgical papers that suggest that stiffness might be protective in the longer term. Again, you can find as many papers that support that as, if you like, dispute it. However, if you have a patient who the surgeon wants to be more conservative, then, as I say, the important thing is to set a patient's expectations such that, you know what, this is your surgeon looking out for you. He believes this is going to give you the best outcome. So we're all giving a positive message so our patient doesn't get frustrated. But in somebody like this 52-year-old who clearly wants to get back to things, who ticks all the boxes in that he's not really got any of the major factors in terms of failure, he's got some of the key factors relating to the tear in terms of having a higher risk of developing post-op stiffness. So you can see how we can make that reasoned decision about perhaps getting him doing some early mobilization. But guys, this short, quick Facebook Lives this week, just jumping on to share some more stuff about all things stiff shoulders. So we've looked at those risk factors for developing post-operative stiffness. Importantly, we've looked at the risk factors for failure in patients with rotator cuff repair. And if we know those things, we can kind of make a decision almost on prognosis-based rehabilitation in terms of what's right for that individual patient. And as ever, making sure they have a comprehensive understanding. The multidisciplinary team are all giving the same message in terms of outcomes and that expected recovery period. Now, I think I saw a few little messages, so I'm just going to check and see if we've got any questions this evening. I'm going to have to put my glasses on, guys, because where I am tonight, the screen's a little bit away. So Tim says, frozen shoulders caused primarily by inflammation. What's your opinion on using steroid injections? So if you get Tim, at the beginning of this, I just announced we've actually released our free frozen shoulder webinar series this week, and we talk all about that. And the bottom line is injection actually is well supported because it's more of a neuroimmune response. We see hyperplasia and yes, inflammation, but then we see myofibroblasts and fibroblast proliferation. Try and get my words out. And actually a corticosteroid injection would seem to downregulate that. So actually steroid is probably one of the most supported interventions. And would you, so Tom, thank you very much for contributing. So when would you suggest a steroid injection? I think that the evidence supports the earlier we do it, the better. However, if you look at all the systematic reviews about injection, essentially it is effective at any point in terms of pain relief. So if pain is a feature, it helps. But obviously once you're in that stiff phase, it has a much less predictable outcome in terms of range of movement. So it's a facilitator, if you like. I'll have a look at that paper later. Thank you, Tom. Abby, thoughts? Oh, yes. Thank you so much, Abby. P-acnes, I'm going to call it, because clearly my pronunciation tonight's not doing very well. So Abby's talked about P-acnes. This is getting a lot of interest at the moment. So it's just a normally occurring bug on your skin. And increasingly, surgeons have got very excited about its potential role in stiffness. Certainly when you have patients that are younger or patients that perhaps get a stiff shoulder, you treat it, but then they keep getting recurring stiffness or recurring frozen shoulders. And certainly there's some increasing evidence to support that. So definitely one to look out for. There was a really nice paper that won a paper prize at the British Elbow and Shoulder Society a few years ago. And that showed fairly convincingly the role of P. acnes in a post-operative population particularly. So yes, definitely something that's getting some interest at the moment, and something I talked about in our last stiff shoulder series, ironically. Where are we now? What's your thoughts on involvement of the rotator cable? So we know with frozen shoulder, increasingly, we've got this really clear evidence that essentially it starts in the rotator interval and that coracohumeral ligament. And I really love that question, because actually when we see about the pathophysiology, and again, we discussed this a little bit more in that webinar series, so definitely check it out. The bottom line is that we get a cytocontractile protein that triggers the contractor in that rotator interval and coracohumeral ligament, and then this reactive fibrosis, that fibroblast proliferation and differentiation into myofibroblasts as part of the cascade, if you like, of how that disease progresses. So again, what's really interesting, we're getting a lot of interest at the moment, is whether ultrasound or injecting into the rotator interval is the right thing to do. However, I don't think we have enough evidence to say yes one way or the other at the moment. So great questions, guys. Thanks so much. So, guys, this was just a quick Monday night special. I've said 15 minutes as ever. I can't quite keep to time. Thank you so much to everybody who's joined tonight. As I say, I'm going to pop on every evening this week just because we've launched our free webinar series. So we thought it'd be a great opportunity to geek about all things stiff shoulder. It won't be about frozen shoulder on here because that's all in the webinar. So definitely check it out. And also in terms of Tom's just come in with another question about knowing the cause of frozen shoulder. Tom, check out the webinar series. And if it doesn't answer that for you, then please pop on later this week. I don't want to spoil all the content in there because we've taken a long time to put it all together and really try and summarize where the evidence is up. But I think the bottom line is, if you look at what orthopedic surgeons, physios, doctors, everybody means by secondary frozen shoulder, there's a massive lack of consensus. But check out the webinar series. So guys, I'm going to try and be here at 7 o'clock, I think, every evening this week to share something else, stiff shoulder. Hope you enjoyed this evening, and I hope you'll join us again soon. Thanks so much for coming, and hi to everybody that said hi. See you again soon.